Hi, it's Brain Bites with me, Dr. B. Today I'm going to be talking about Wellbutrin, what it's for, how it helps, and what happens if it's not going so well. Let's dig in. So, Wellbutrin is an antidepressant medication. It is an NDRI, which refers to a noradrenergic dopaminergic agent. So it blocks norepinephrine and it blocks dopamine, and that is how it provides the antidepressant effects. So this is a medication that can work for pretty much any type of depression. So it can especially be useful in seasonal affective disorder. So that's the depression that we tend to see more often in the wintertime when the weather is more gray and the days are shorter. So this medication is very good for treating that. Oftentimes, to be successful for treating seasonal affective disorder, the medication gets started before any depressive symptoms show up. So we know when winter is coming, so we can start the medication, get somebody teed up where they need to be, and then they hopefully will not have a depressive episode as they move through the wintertime, and then can even come off the medication once we're into the spring and their symptoms are less likely to return. So even in bipolar depression, bupropion is not a terrible choice of medication. So we do always worry about switch whenever we're putting somebody with a bipolar type disorder on a antidepressant medication. We're always worried about the risk of switch to hypomania or to mania. So that's always a risk with any antidepressant. But it seems that in most cases with bipolar disorder, this medication seems to work fairly well. And there's some thought that it might have to do a little bit with the half-life of the medication not being as long as some other antidepressants. But no matter what, it looks like in some cases of bipolar depression, this medication can be helpful. Now, there's a lot of literature out there that says we don't treat bipolar depression with antidepressants. I go based on the patient, so treating the individual. I do have bipolar patients that are on Wellbutrin. We watch very carefully for any signs of activation where it looks like they're moving into hypomania or mania, and we pull it off real quickly if that sort of happens. But as long as they're mood stabilized, so they're taking their mood stabilizing medication, in general, I have found for most of my patients that it is safe, and I have only had one patient switch, and it was not a big disaster. We caught it very early, and we were able to keep it under control. So it's not just for depression, though. So it can also be used for smoking cessation. This is a medication known as Zyban. So it's the same formulation of the medication, but it was marketed differently. And it was for smoking cessation. So helping people quit smoking. You can do a single course of 6 weeks, and that's been shown to be very effective. And patients can take it for up to 6 months if they're struggling or if they need a little more help. But it has been shown to be effective for smoking cessation. Some people, it does help with weight loss. So this is considered a weight neutral antidepressant. Most antidepressants that are newer are considered weight neutral. But it can even cause some anorexia, meaning it just makes people feel like they're not hungry. So in some cases, it can help people with weight loss. And also, a really common use of this medication is for ADHD patients. So for patients that can't tolerate stimulants, who stimulants are just not a good choice, Wellbutrin is an option for helping to treat some of those symptoms of ADHD. One thing that it really doesn't help with is it doesn't help with anxiety. One of the things I often see when I get referrals from primary care, and I'm not really sure how this happens so consistently, but it seems like a lot of patients that come to me on this medication from primary care also either have a comorbid anxiety disorder or anxiety is their main thing and they are started on Wellbutrin. Wellbutrin does not hit serotonin, and serotonin is usually implicated in anxiety disorders. So this is not a good medication for somebody who has just anxiety. So if you have a client who comes in and is like, oh my gosh, my doctor started me on this medication and I feel so much more anxious than I did before, and they don't have depression, or they have depression and they have an anxiety disorder, and they were only started on Wellbutrin, that's a good sign that maybe this isn't a good fit medication if it's a standalone medication. So it doesn't treat anxiety. Now, it can still help if somebody has a depression that's presenting with anxiety. So an anxious depression. That can still be treated, but it's the comorbid anxiety disorders that we're pretty sure are serotonin based. Those disorders will not be treated by this medication. Okay, so I alluded to a little bit what kind of medication it is. It's a noradrenergic dopaminergic antidepressant, so an NDRI. We don't completely understand exactly how it works. So we do know it blocks norepinephrine reuptake and it blocks dopamine uptake. But it seems like when they are looking at these chemical studies, that it's not blocking it very significantly. So we're not sure exactly what's going on with the action of this medication. Now, some of the things we do know is it does have active metabolites. So the drug gets broken down, and what it's broken down into, those pieces are active. So it does have some effects that probably are coming from that piece. It can be kind of considered a prodrug. So the body takes it in, breaks it down, and then it has more action once it's broken down. In which case, if somebody has trouble metabolizing the medication, it's probably not going to be as effective. So it also has to do with where it's effective in the brain. There is a lot of feedback information between the norepinephrine and the dopamine. When there's more norepi around, especially in the prefrontal cortex, it also helps to increase the level of dopamine. So that may be part of the antidepressant effects that we're seeing. It's interacting on a couple of different pathways and they feed on each other, causing more of an improvement than we would expect. So just a little aside on the medication. So Wellbutrin is considered to be an activating medication, and that can be a good thing or a bad thing. So for some people, the activation is positive because it causes them to feel more energetic and they have more motivation and they want to do more. For some people, that can cause sort of a restless feeling, or it can look like it's leading into hypomania or mania. So that kind of activation, it can be a positive thing for some patients and a negative thing for others. So that's just a thing to keep in mind. We know that this medication is activating. It's just a question of whether or not we want it to activate the particular patient that we prescribe it for. So there are different formulations of this medication. So Wellbutrin, bupropion can come in an immediate release, which is dosed 3 times a day in best case scenario. And then there's a sustained release, which is dosed twice a day. And then there's an extended release, which is dosed once a day in the morning, because that is when the norepi is going to hit. And we don't want to give that to people right before they're going to bed. So those are the 3 formulations. In general, I prescribe the XL to everyone. So the extended release, the once a day is best. If we can prescribe things so people only have to take it once a day, that's going to be much better for compliance than prescribing something that needs to be taken 3 times a day. Now, if patients really struggle with taking the medication, sometimes the immediate release is better tolerated. So we can start somebody on the lowest dose of the immediate release. Most of the time, it doesn't work out that well for my patients, but it is something worth trying if somebody's really convinced that Wellbutrin is the thing that's going to help them. And then sometimes for my patients that struggle with ADHD and like a little bit of Wellbutrin to help them when they need it, I do have a few patients that when they know they're going to have a long day at work or if they are going to have a late meeting, they will take the immediate release of Wellbutrin early on. So one of the things to know, because this is a longer acting formulation, it can't be cut or crushed. But there are patients that will crush this medication to abuse it. So it can be crushed and snorted. This can be a big problem in corrections. So a lot of patients will get their medications. This is one that is active. So when they crush it up and snort it, they will get an effect. So it does have some amphetamine-like actions. So that's why we think that it's helpful for ADHD. So if patients are crushing up, they may get that effect, like they're getting a boost, they're getting that lot of energy, just as if they were to snort a stimulant or cocaine. So that's just something to keep in mind. Most of our patients are not abusing their medications. So even though this medication has norepinephrine in it, and you can feel the effects pretty quickly, in general, to see the full antidepressant effects, it's still going to take a few weeks. I tend to see that my patients start feeling any effects sooner than with SSRIs. So they tend to feel really positive about the medication because they can sense that norepi action early on. So I do try to sell them a little bit on it. Like, you're going to feel better a little bit sooner. You know, they do feel that energy boost a lot of times. Sometimes they feel a little overactivated, but usually that fades once their body gets used to the medication. So I don't treat that as too negative. But overall, this medication is good because it does provide some sense that something positive is happening, that the patient tends to feel earlier than the 4 to 6 weeks that we see with some SSRIs. So the effect still may take 2 to 4 weeks to see the full effects, but I tend to think that people start to feel better a little bit sooner on this medication. So, in general, this medication has a really positive side effect profile. So, it's really a generally well tolerated medication. The most common side effects that people complain about are insomnia. So, it interferes with people's sleep, and that's generally the norepinephrine. It can cause dry mouth and it can cause tremor. So, tremor is part of that activation. It can make people feel a little shaky or jittery. I've had patients describe it as it's like having too much coffee. So, it can be sort of an uncomfortable restlessness right in the beginning. Other common side effects, but not quite as common: headaches, agitation, nausea, sweating, decreased appetite, and sometimes hypertension. So, if somebody already has problems with their blood pressure, it can cause an increase in their blood pressure. Again, it doesn't stimulate the appetite, so it doesn't cause people to gain weight. And sometimes it may actually cause people to lose their appetite, so they may lose some weight. And it doesn't typically cause orthostatic hypotension, so it doesn't cause that dizziness from a drop in blood pressure. There is a warning. So, for people that are at risk of having a seizure, so people coming off of a lot of alcohol or who use a lot of benzos and are trying to quit, or people who have a known seizure disorder, this medication is generally not the best because it is shown in those populations to put people at greater risk of having a seizure. So, the other two groups of people are in eating disorders, the bulimics and anorexics, also not great candidates for this medication because of the lower seizure threshold. So it makes them just more likely to have a seizure. It doesn't mean they will have a seizure if they take this medication, but it is something to be aware of in a population. If they have a seizure disorder or if they use a lot of benzos and they're going to come off really quickly, it's maybe not the best timing for this medication. In overdose, this medication is generally safe. There are very few deaths from this medication in overdose, and it generally relates back to the neurological complications. So, status epilepticus, where somebody has a seizure and they can't get pulled out of it. But in general, it is very hard for people to overdose with the intent of death on this medication. So I tend to taper this medication. Most patients handle coming off it pretty well. There's no indication that it has to be tapered, but I mean, if we can taper it, let's taper it. But that said, for the XL formulation, 150 is the lowest dose. It goes up to 450 and it goes down to 150. So once they're at 150, we pull it off. They can't cut it in half, remember, because it's an extended release. But people will complain about some side effects when they come off the medication. It's not necessarily a physiological withdrawal. It's more that they've gotten used to being on the medication and the effects that it provides. So people often will feel less energy. They will feel more tired or like they're dragging more in the morning. And that's because they no longer are getting that little boost of epinephrine. So it's not a huge problem physiologically taking off this medication. So if patients run out of it, it's not the worst thing ever. They won't feel terrible from the medication withdrawal, but just losing the effect of that medication can feel kind of bad. And the final thing is that because of the way this medication is metabolized, it's metabolized in the liver in the P450 system. And the enzyme that metabolizes it is CYP2D6. So this is not a pathway that's used for a ton of medications. So in general, this medication also isn't a problem to take with most other medications. I tend not to provide this medication if people are on a lot of stimulating medications already, but in general, it can play really well with other medications. And with that, we often use this as an adjunct with SSRIs. So there are two reasons why we would do this. So the first reason is that this is a great medication to try to counteract sexual side effects that we see with SSRIs. In general, Wellbutrin itself does not cause sexual side effects. Occasionally, I'll have somebody that complains of that and says it does. But it can be helpful for other patients who are having those sexual side effects while they're taking Prozac or Zoloft, because this medication will provide antidepressant effects and can help with counteracting those sexual side effects. And then, of course, if somebody is not seeing full response with their SSRIs for their depression, this medication is a great adjunct, especially in that slowed down depression where people are feeling tired and spending too much time in bed and just not having the motivation to get up and go. So hopefully this has been helpful and you've learned a little bit more about Wellbutrin, which one of your clients should probably be on it and which one of your clients probably shouldn't. This has been Brain Bites with Dr. Beachkovsky. Hope you're full of Wellbutrin goodness. Enjoy.